Good afternoon, everyone, and welcome to the October Food for Thought seminar. I'd like to start by acknowledging the traditional owners of the land on which we meet today, the Whadjuk people of the Noongar Nation, and we recognise their ongoing connection to the land and their contributions to the life of our city and state. I pay my respects to elders past, present and emerging, and extend that respect to any Aboriginal and Torres Strait Islander peoples who are joining us today. Please take a moment now to turn off your mobile phones or put them on silent. Before I introduce today's speaker, I'm very pleased to share that work on the courtyard is almost complete, as most of you will have noticed, and soon we'll all be able to enjoy that cup of coffee in beautiful surroundings in front of this building. And I just want to thank you once again for your patience while this project has been underway. Over the past couple of months, the Foundation has been busy assessing over the past month I should have said, we've been busy assessing applications for both our Ignition grants and our research awards, and the winners will be announced later this month, and we do encourage you to look out for these important announcements. Finally, I do want to congratulate Professor Marcus Schleich on a fantastic tenure as the 2024 Scientist of the Year, an award that recognises outstanding individuals for excellence in their field of science. We're all very proud to share in that achievement, Marcus. The next Food for Thought will be our final one for 2025 and will be held on November the 13th, and we'll share more details about this with you soon. But it's now my great pleasure to introduce today's speaker, Dr. Zi Ng. She is an early career hematologist and clinician researcher with a focus on myeloproliferative neoplasms. She has recently rejoined the hematology department at Royal Perth Hospital following a dedicated myeloproliferative fellowship with Professor Claire Harrison, a world leader in this field. Dr. Ng is actively involved in translational research and serves as an investigator in clinical trials, contributing to advances that bridge laboratory science with patient care. I'd also like to thank once again Professor Schleich, who will facilitate the Q&A session and officially close out the event. So please now join me in welcoming Dr. Ng, who will present Decoding Myeloproliferative Neoplasm, State of Play in 2025.
Hello everyone, thank you Kate for the very kind introduction. Okay, so today I have a brief to discuss myeloproliferative neoplasms, or MPN for short, and what's actually happening in the field in 2025. Okay, so I guess most people have heard of leukemia, maybe myeloma, or lymphoma, but many people probably have not heard of myeloproliferative neoplasms, or MPN for short. What are MPNs? They're actually a type of rare bone marrow cancer that leads to there's actually too many blood cells. And it's actually a rare type of blood cancer, estimated to be less than 10 per 100,000 persons. I'm going to introduce to you the three of the more common types of MPN. I've listed chronic myeloid leukemia on the right because that's one of the common types of MPN, but not the subject of today's talk, because it is quite different from the three different MPNs that I'm going to be discussing today. So for the three common types of MPNs I'm going to be discussing today, so there is one which is polycythemia vera, or PV for short. As you can see in the pictorial, they have too many red blood cells, too many platelets, and too many white blood cells. Or essential thrombocythemia, or ET for short, they have too many platelets. And these two are more early stage of the MPNs, while the third other type of MPN I'm going to be discussing today is myelofibrosis, where actually there is scarring of the bone marrow. Initially, they have too many blood cells, but eventually they become quite cytopenic with low blood cells and significant symptoms. Just talking in brief about the history of MPN. As you can see from the left part of the slide, this was described by various physicians, pathologists, and even a general surgeon. in the 1800s, describing the different entities that I've mentioned. It was only in the 1950s where William Demyschek, pictured in the picture on the bottom right, introduced the concepts of myeloproliferative neoplasms. Not much happened for 50 years until it was actually in the 2005 where we are in the era of gene mutation discovery, where they discovered the JAK2 V617F mutation, and that is the most common mutation in MPN. So this was in 2005. This led to an explosion of knowledge where different mutations were described subsequently. So 2007, they discovered the JAK2 exon 12 mutation. And it was in 2008, they discovered the MPO mutation. And 2013, where they discovered the CALR mutation. And this is the second most common mutation. And I'll discuss this in more detail later of the presentation. But so it was because of all these genetic mutations, they decided that it's a cancer of the stem cells. So it's classified as a blood cancer officially in 2008 by WHO. So I have described the different entities of MPN, but what are the problems that the patients have? So they have, the first one of the problems they have is significant thrombosis risk. So this can be arterial blood clots in terms of heart attacks, strokes, or they can have venous thrombosis as well. And some of them actually have very odd areas of thrombosis, so like portovenous thrombosis or cerebral venous thrombosis as well. So if you have a patient with this sort of condition, they're not quite sure why they have this problem, it probably is worth considering NPN. The other problems the patients do suffer is very significant constitutional symptoms that are depicted in this pictorial below. So patients actually really feel very unwell with significant fatigue. They get fevers, sweats, they actually lose quite a lot of weight. Some people have problems with itchiness and significant bone pain. And some patients have a really big spleen, and that causes the problems with feeling full easily when they eat, and quite a bit of abdominal discomfort as well. They also have other problems in terms of what they call brain fog, where they feel problems concentrating with their daily tasks and also feeling very inactive as well. Some of the other problems the patients face, so these are technically chronic type of blood cancers, but the problems is when they have disease progression, this is when it leads to reduced life expectancy. And how this usually folds up is, so patients with polycythemia vera and essential thrombocythemia, we are early stages of the disease, they can progress to myelofibrosis, so the later stage of the disease, but there are patients who also present in frank primary myelofibrosis straight up as well. Less common, but very devastating when this happens. The patients in these three groups of MPN can also progress to acute leukemia, or the other term is blast phase MPN, and they usually have a very poor prognosis when this happens. So for the next part of the talk, I'm going to be discussing first about PV, or polycythemia vera, and essential thrombocythemia, and what we currently do for these patients. So I have mentioned that one of the problems the patients have is thrombosis. So the first part would be in terms of, it kind of makes sense to investigate antiplatelets. So this was the ECLAC study, which was presented or published in 2004, and they compared aspirin versus placebo. As you can see quite nicely from the graph, that aspirin was superior in reducing thrombosis, thrombotic events and cardiovascular events. So hence, currently now antiplatelets is a standard of care for the patients with MPN. The second part is, I've mentioned that the problem they have is they have too many blood cells with different lineages. So this study, which is the CYTO-PV study, was looking at in patients with polycythemia vera, so too many red blood cells, if they aim for a lower hematocrit, so in this case, how thick the blood is. So in this case, aiming for 45% or less, whether or compared to a less strict hematocrit, was this more superior? And you can see from the graph that aiming for a hematocrit of less than 45% was superior in terms of reducing thrombotic events as well. So hence, for patients with polycythemia, this is also standard of care in terms of aiming for a hematocrit of less than 45%. Now, in terms of the traditional treatment, I guess, paradigm in terms of what are considered high-risk patients, we have talked about antiplatelets and controlling the blood counts with phlebotomy. What we term as cytoreduction means specific therapy to reduce the blood cells. This is only strategy started if they are above 60 and above due to increased risk of cardiovascular events and thrombotic events in this cohort, or if they have the prior thrombotic event, which makes sense because it means that they have really high risk from their clinical features. However, I think this begs further thought. in terms of maybe low risk PV, which is the group and the bar in the pink here, that maybe it's not as low risk. I think they do have problems in terms of thrombosis. So this bar chart is trying to show that they are comparing low risk and high risk PV patients compared to the general population in blue. And you can see that, for example, let's compare with the dark blue. This is the general population with multiple cardiovascular risk factors. So their incidence rate of anorrhea of thrombosis is 0.9. And as we know probably from the cohort here is that we do a lot of interventions for these patients. We put them aspirin, statin, we control their diabetes and high blood pressure. While this technically apparently low risk patients have more than double the risk of incident risk of thrombosis. So it's actually antiplatelets and venisections, antiplatelets and venisections the right strategy? Do we need to be doing more for this group of patients especially? So I've mentioned in terms of currently we are controlling the blood counts, but actually we're not modifying the disease outcome in the long term. The first 3 treatments I've listed here are mainly controlling blood counts, so phlebotomy, just removing blood, donating blood. Hydroxycarbamide is an oral chemotherapy that's very effective at controlling blood counts, but it's been around for very long and we know that it doesn't modify the disease. While anagrelide, which is a medication that inhibits the megakaryocytes, the cells that produce the platelets, also an effective drug, quite a few side effects, and actually there's some evidence that it seems patients on this drug can actually have an increased risk of progressing to fibrosis. So we definitely, with these 3 agents, we are controlling the blood counts, but not really modifying the disease. Do we have any other treatments we have our sleeve? So I've listed 2 here. So one is pegylated interferon. So interferon has obviously been around for a very long time, treating other diseases like hepatitis C, for example. Now that they have made the formulation pegylated, it's more tolerable for patients. And actually, there's quite a lot of evidence now for pegylated interferon in MPN, where they found over time, which I'll discuss in the next slide, that it does modify the disease. Other agents such as ruxolitinib, which is a JAK inhibitor, has also to have some evidence in this area as well. So this is one of the studies showing that pegylated interferon probably does modify the disease over time. I mentioned that these patients are chronic blood cancers, and the risk of disease progression is a small percentage of patients. So that means that you really need a large cohort of patients over a very, very long period of time to actually show a benefit. So you can see this retrospective study, this is over 28 years. So that's a very long time that we're trying to show this benefit. And if you focus on the graph or the Kaplan-Meier curve on the top, this is looking at myelofibrosis-free survival. So the risk of the risk of not having myelofibrosis. Patients with treated with interferon are the ones in pink. Green is hydroxyurea, and blue is just phlebotomy only. As you can see in these low-risk patients, PV, polycythemia vera, interferon was actually superior in improving myelofibrosis-free survival for these patients. Now, if you focus now on the second graph, this is looking at high-risk patients. So these are the patients who are more likely to progress and have significant complications. It's the same trend where patients treated with interferon actually have improved overall survival compared to patients treated with other traditional therapies, so hydroxyurea and phlebotomy. So in my practice, unless there's a contraindication, I would recommend pegylated interferon first up for these patients due to the data that we can see. Okay, so I've talked about what the current treatments that we have available. I think we have a lot of upcoming treatments now in ET and PV, and a lot of them are in clinical trials, so I wanted to discuss them briefly. So there's agents such as hepcidin mimetics. So the problem with polycythemia is there's excessive red blood cell production and patients get iron deficiency. So how this works is basically it degrades ferroportin, which is part of iron recycling, and then that blocks it, and the problem patients will have less proliferative red cells and need less venisections. Other drugs such as bomimdemstat, which is an LSD1 inhibitor, also has some very exciting data in ET, and currently actually we have a clinical trial ongoing in Royal Perth for ET patients. So if you have any suitable patients, feel free to refer. Selective JAK2 inhibitor, so this is a newer type of JAK2 inhibitors, not the ones I've discussed before. These are still very new, just started to be in clinical trials, and probably the first readout will be in end of this year. So it will be very interesting to see how this works, because some of them actually change the mutated JAK2 to a wild type phenotype. Also very exciting in terms of CALR targeting agents. So this is the CALR mutation that I mentioned before, the second most common mutation. We now have agents in clinical trials targeting specific the CALR mutation. So there's a monoclonal antibody being studied at Insight. We have a few sites in Australia. There's also a bispecific antibody by Janssen that's also being studied in trials. And then there's also other groups in the UK. I was looking at a CAR T therapy, but this is currently still preclinical. So really, really exciting times for these patients. Okay, so I have discussed about polycythemia vera and ET. I've mentioned about the problems they can have in terms of they can progress to myelofibrosis. And these are some of the incidents where you can see over 15 years, there's up to 5 to 10% that can progress still. So it's still a significant number of people. Is there anything we can do to predict or even prevent the disease progression? Unfortunately, currently, no, we don't have any robust way to predict disease progression, because as mentioned before, very big group of patients, a smaller percentage of a disease progression. So you really need to have very robust data. So this is what the MPN Research Foundation in the US is trying to do. So by working with patients, clinicians, and other stakeholders, they are hoping to have, actually end of this year probably, an MPN progression registry. So if we have more data, we'll be able to answer some of these questions, hopefully, over time. But maybe there is something a bit more local in Perth. So this is part with the group at UWA, Translational Cancer Pathology Laboratory. This was published in 2020 by Dr. Goh and the team, where they were looking at the transcriptomic profile of platelets, because the reason we have chosen platelets is when we look at the bone marrow biopsies of this patient, quite often the megakaryocytes, the cells that produce the platelets, actually look really abnormal. So our hypothesis is maybe there's something wrong with the megakaryocytes that's causing this disease. And obviously it's easier to study platelets rather than megakaryocytes in the bone marrow. So in this study, they have shown that patients, so in green, which is the patients without fibrosis, has a distinct platelet transcriptomic profile compared to the patients with fibrosis. And through the analysis, they identified 3 genes, they call it a 3-gene signature here, that seems to be relatively robust to predict disease progression, so from PVET to myelofibrosis. So this was the preliminary data, and as you can see, the positive predictive value is about 70%, but the negative predictive value is quite good at 92%, so it could be used as a screening test in terms of predicting disease progression. We are currently bringing forward this method for further investigation in different patient cohorts as well, so wait for further data in the future. Okay, so I have already discussed PV and ET earlier, so now I'm going to change tack now and talk about myelofibrosis. So I mentioned earlier before, this is a more advanced stage of MPN. Patients have problems with bone marrow scarring and they feel really, really unwell. Okay, unfortunately, the only curative option for these patients is allogeneic bone marrow transplant. But because a lot of the patients, when they're diagnosed, are older, they might not be that fit, they might have a lot of comorbidities, so only 10% of patients are eligible. And even if they're eligible, it doesn't mean they'll get to a bone marrow transplant, because there's a lot of barriers you need to overcome to get there. What do we do for these patients otherwise if they can't have a bone marrow transplant? So there's supportive care. So in terms of if they have problems with anemia, which is a big problem in myelofibrosis, we can use agents such as EPO-stimulating agents, which can be helpful in certain cases. We have JAK inhibitors, where currently there's 4 available globally, but only in Australia we have the first 2, which I'll discuss in the next few slides. They are good treatment, in terms of really helpful with improving the symptoms that the patient have and reducing the spleen, but these are not long-term treatment options. So for example, for ruxolitinib, which has been around a bit longer, the median time of response is about 3 to 4 years, so that's not a very long time at all. There's also some emerging evidence of using pegylated interferon as well in the patients with earlier myelofibrosis as well. And that's to hopefully impede the disease progression. So I'm just going to go through about the JAK inhibitors that I mentioned earlier in myelofibrosis. So this is the COMFORT-1 study where they look at patients were either randomized to ruxolitinib or placebo, because at that stage there was no other treatments available for myelofibrosis. As you can see here from the graph on the left, the orange bars and the waterfall plot shows that they're very good at reducing splenic volume for these patients. While the the graphs on the right are showing that they're also very good at improving the symptoms as well for these patients. But as I mentioned earlier, they work well, but it's not a durable response. The second JAK inhibitor that we have available in Australia is momelotinib, and that's only been approved April this year. So actually there was no other treatment for 15 years besides ruxolitinib. So momelotinib is also a JAK1/2 inhibitor, but it has an additional target. It targets ACVR1, and due to this different mechanism, it has a benefit in terms of improving anemia. So patients treated with ruxolitinib earlier, they actually have problems with anemia. It actually worsens anemia. And patients with myelofibrosis, a lot of them really have problems with anemia, so you're sort of increasing transfusions for them. But this agent that has come on, as you can see from the solid symbol, so the squares and the triangles, they were better in improving anemia compared to the other agents that's being tested. I think the future is bright in myelofibrosis. So this diagram is mainly showing that there's a lot of different mechanisms that's currently being studied in myelofibrosis. So just to name a few, so this one we're looking at the MDM2 pathway with a drug called neftametlin, and we actually have a clinical trial with this in Royal Perth as well. So please feel free to refer if you have any suitable patients. There is also XPO1 inhibitors like selinexor also available at different sites in Western Australia. There are also things such as telomerase inhibitors called imetelstat, not available in Western Australia, but actually have very exciting data in the phase 1-2 clinical trials where they actually improve overall survival, which is really amazing. And there's a currently phase 3 clinical trial ongoing. So I have mentioned that a lot of these patients live for many years. So it's very hard to run a clinical trial more than 5 years due to fundings and logistics. So I think we really need better biomarkers as a surrogate endpoint to look at whether a drug improves the event-free and overall survival. What are some of the potential biomarkers? So we could look at the cytokines profiling, because a lot of these patients have really abnormal cytokines and causes a lot of the symptoms. We could have enhanced bone marrow assessment. So for example, there's some studies looking at spatial transcriptomics to further understand the MPN bone marrows. AI could probably be a way to help pathologists as well with this. We also perform mutation panels, but not in all patients. So we probably could expand this to accommodate more patients so we can understand better their risk profile. What I'm going to discuss next is looking at the molecular response of the driver mutations. So what does this really mean? So I had mentioned in an earlier slide that patients with MPN have 3 common types of driver mutations. So this is the mutation that's actually driving the disease. So the JAK2 V617F mutation is the most common type of mutation in MPN. So it's almost 90-95% in patients with PV and about half of patients in ETMF. The second most common mutation is the CALR mutation, and there's about 1/3 of patients with ET and MF. And then the MIPO mutation, which is least common, only 5% of patients. And I think this is interesting because currently for many blood cancers, we actually really look at the molecular dynamics, and besides routine bone marrow biopsies and things, we look at how their molecular changes change over time, and that gives us a good indication of how the treatment is going. So we're talking about like minimal residual monitoring. So I guess the question from the research is, can we use molecular response to inform management in MPN? So before we talk about the research, I just wanted to introduce to the audience the concept of JAK2 variant allele frequency so that we understand the next few slides. This could be, maybe a lot of people already understand this, but this is a pictorial on the right trying to explain that the VAF, variant allele frequency, is looking at the percentage of variant or abnormal alleles over total alleles and getting to a percentage. So how many percent that the patient has the mutated allele. Currently, the response criteria, meaning that how do we ascertain what sort of response they have molecularly, this is still fairly straightforward at this stage. So complete molecular remission, meaning that they have eradication of the previous mutation, or partial molecular remission, so 50% reduction compared to the baseline as well. So all fairly still very straightforward. Now, but there are some problems with this test. Number one, the test is non-standardized. So it means that if a patient goes to 2 different laboratories on the same day and have the test done, you could get very vastly different results. So that's not very helpful for us if you're trying to monitor whether your treatment is working or not. There's also a problem in terms of how often should we be doing this test? Should we be doing 3 monthly? Should we be doing it yearly? And does it depend on what sort of treatment you're on? So there's still a lot, I think, in the field that we need to come onto a consensus. So as part of my research, I was fortunate to be awarded the St. Minchin Scholarship, awarded by International Council of Standardization of Hematology. And part of this, from part of this grant, we are collaborating with UK NEQUAS. So this is a UK-based external quality assurance body where they basically send out JAK2 samples to various type of samples, including JAK2, to different laboratories and score how they do. So there's already a lot of data available for I think 15 years that we're trying to analyze. And the hope from the ongoing research is that we're trying to work out there's different ways of doing the test, which laboratory method is best, and which laboratory method is able to detect smaller changes as well. So this research is currently ongoing. Okay, I have talked about some of the problems with the test, but why is it actually important? So we're going to focus first on the JAK2 molecular responses, as that's the most common. So this results from the MAGIC PV trial, which is basically looking at high-risk PV patients. They were comparing ruxolitinib, a JAK2 inhibitor, versus best available therapy. And from the Kaplan-Meier curve on the right, this is looking at event-free survival by their molecular response. Meaning, so patients in the orange curve, they have at least a partial response molecularly. So this is talking about the WEF, the JAK2 WEF. They did better compared to patients who had no response. And the most important thing, I think, is to say that this is regardless of what treatment arm you're on. So it means that it doesn't really matter which treatment, as long as you get there and improve your molecular response, you do better. So they have better event-free survival, and this also translated to improved progression-free survival, actually overall survival as well. And it's also good to see that when patients have a molecular response, they were actually durable as well, so it wasn't just transient. There's other studies that also look into this. So Gugamelli also looked at ruxolitinib in PVET that showed similar results in terms of improved event-free survival. The PROUD-PV study, which was comparing Ro-Peg interferon, a different version of pegylated interferon, comparing against hydroxycarbamide, they also showed that Ro-Peg interferon had improved event-free survival as well. So I think this goes to show that it is actually a good marker in terms of looking at overall clinical outcome. But I mentioned about JAK2 V617F. What about the second most common mutation, which is the CALR mutation? So when I was doing my MPN fellowship in the UK, I was interested in this question. I had a look, did a literature search. There was actually not much data on this. So that's why we decided to look at having international collaboration, retrospective study, looking at the CALR variant allele frequency and how it changes with different therapy in MPN. So this was presented as an oral presentation at the American conference last year. I'll just give you a quick snapshot of the results. So as you can see from the first two waterfall plots on the top, patients treated with interferon and ruxolitinib have a reduction in their WEF, so that looks good. While patients treated with hydroxycarbamide has varying, some have reduction, some have increase. While interestingly in this research, we found that patients treated with enagrelide, the drug that I mentioned earlier that seemed to increase risk of fibrosis, all but one had increase in their WEF. So I think it's interesting to know that maybe, this drug has a signal that increases fibrosis. Can the changes in WEF be a good correlation for that? So I'll be updating this data in comparing the CALR mutated patients with the JAK2 patients, and be presenting it at the Australian Blood Conference actually end of this month. Okay, so we've talked about some of the trajectories of MPN. as I mentioned before, these 3 types of MPN can progress to acute leukemia, and those are some of the numbers. So, over 10 years, 1 in 5 could progress to myelofibrosis. So that's still a fairly high percentage. While over 15 years, it's about 5 to 15 or 19%, depending on which study you look at. And I think this is really important to know, because actually when they progress to acute leukemia, the median survival is actually less than a year, only 5 months. So the patients actually do very poorly. There's not many therapies for this patient. So I guess the next question is, can we predict who is going to progress to acute leukemia? Because there are many patients who is not going to progress. We don't want to overtreat those patients, but we really need to target the patients who have high risk of progression. So I'm going to introduce you to this technique, which actually has been presented prior. So part of the group at Translational Cancer Pathology Laboratory introduced you to this WA-invented technology, immunoflow fish. So this is looking at the single-cell genetic method, where they can look at, in just using one method, analyzing hundreds of thousands of cells, you can have quite a lot of information. So, by this test, you can understand the immune phenotype of the cell, so what sort of cell it is, using flow cytometry principles, and also we have digital cameras on our analyzers. But not only that, we can also perform fish fluorescent in situ hybridization, so understand the chromosomal makeup of these cells. So getting a lot of information from just one test. So I'll just walk through you briefly of this gallery if you're not familiar with this. So each row represents a cell. The first row, as you can see, this is it's bright for CD3, so this is a T cell, and this is looking at the chromosome. So this is chromosome 12, and you have 2 copies of this. While these 2, they are B cells, because these 2 has positive for CD19. But the second cell has 2 copies of chromosome 12, but the third cell, as you can see very nicely, 3 yellow dots still have 3 copies of chromosome 12. So really powerful method. So you know that the patient has trisomy 12, but it's also in the B cell as well in this case. So this technique, the immunoflow fish, actually part of the inventors of the group, won the Eureka Prize in 2018 for innovative use of technology. This is a very specific, what cell you're looking at, a very sensitive method. So 1 in 100,000 cells, you're able to detect this genetic abnormality. And we are very fortunate that RPH Research Foundation awarded us a grant last year, where we're going to be studying 100 patients with pre-existing bone marrow disorders, and to see whether we can use this really powerful test, immunoflow fish, to detect the leukemia genetic switch. As you can see, this is the group that's very happy when they've got the award. I'm actually not in this picture because I was actually in the UK doing my fellowship then. Some of the last few slides, this is an example of a patient with MPN, where this is the first 2 slides to show that she has an overactive bone marrow, and we are wanting to hold that we can detect, predict, and prevent progression to acute leukemia. So the gallery here, the main thing to focus on is this third column, where you can see chromosome 17. The first cell has 2 normal copies, while the second cell has only 1 copy. So there's loss of 1 copy, which is actually really important, because this usually leads to TP53 deletion or mutation, and has significant prognostic implications. So I think we have shown that immunoflow fish is a very powerful tool, and it will be exciting to perform the research over the next few years to look at the results of the test. The last few slides, it's important that we talk about what are the current treatments and upcoming trials and things, but I think it's also very important to empower, educate, and engage with our consumers and our patients. So I'm really proud to present that together, Royal Perth Hospital with UWA School of Biomedical Science, and also with MPN Alliance Australia, which is the patient group, we are going to be presenting an education symposium end of this month. And so the education symposium is for patients, carers, and also for clinicians and researchers as well, because not many people know about this disease. So I think it's really good that people can come. If you're interested, please feel free to register. It's only in the Wason building, not too far from here. And this is my last slide to say that first, I think not many people know about MPN, so it's really important to have increased awareness, which is why I'm here today, and also really important to have improved diagnosis of MPN. I think the fact that the disease as I say, we don't really understand a lot of in terms of the risk of disease progression. Actually, we don't really have a lot of very good registry data in terms of how common or how prevalent is the disease. So we really need large longitudinal databases and real world to understand this. And alongside clinical databases, we should also work together to have a biobank of blood and bone marrow samples, because I think together, hopefully we can find a robust biomarker that will be really good to as a surrogate for clinical endpoints. I think if we have a very robust biomarker, when we do clinical trials, we will be able to read out the result quicker to know that, yep, this drug does lead to clinical benefit for the patient. Lastly, but most importantly, it's always important to engage with our consumers so we understand what's actually important for them, what do they need to learn about their disease, and having symposiums for this. And also working in a collaborative fashion, because our patients have actually quite a lot of different problems, like in terms of blood clots. Some of them can have end-stage liver problems from their blood clots as well. So working with the gastroenterologist or neurologist if they have, brain clots as well. So always important to have a conversation. And with that, thank you for your attention. Please, happy to answer any questions.
Thank you so much for this excellent presentation, and I think it's always an eye-opener to hear about a condition we perhaps don't hear about too much, and always shocking to see the prognosis, particularly with the blast phase. 5 months median survival rate is very, very poor, of course. So, and congrats to all the awards. We do have opportunity for questions. May I start with one? What is actually the most common cause of death in patients with myelofibrosis? And those in the blast phase, that's probably more obvious. But what do they ultimately die from?
For myelofibrosis?
Correct.
Yeah, so for myelofibrosis, actually they found that it was actually cytopenias and the clinical problems with cytopenia. So infection usually is the most common cause of death because they have low neutrophil counts, they can't fight infection, and because their condition is actually not very good, they are really cachectic, they've lost weight. So, if despite all the best treatment, they just can't fight the infection. And obviously, the other thing would be risk of progressing to acute leukemia, which I guess is obvious in terms of why they die from that as well.
And coming from the other side in terms of what causes it, we have heard quite a bit about the genetic kind of makeup, and that can play a role. And you've elegantly highlighted which candidates are most relevant in that context. But in environmental factors, what other kind of conditions predispose people to develop ET, PV, and ultimately myelofibrosis?
So very good question. The answer is we don't know. But actually there is a group in, I think, Scotland, if I remember correctly, they're actually looking into this. So they are actually performing, not registry, but I can't remember the term, but basically they're comparing patients and a healthy person to look at what are the risk factors as well. So they are actually, that would be very interesting to see, whether it's exposure since young. I suspect it's probably a combination of multiple factors that will be quite hard to tease out. Some of the interesting research we have not shown here is that actually the JAK2 mutation has sometimes actually present for a very long time before it actually has a clinical presentation. So there are some where they actually has in utero as well. So actually very long lead time before someone has the disease problems.
And open it up in a second. You mentioned that most of the drugs that are currently being used are really there to control the cell numbers, essentially, while they're not necessarily disease modifying. You did show, particularly the pegylated interferon. Is that kind of the biggest hope at the moment, or where do you see, like, hopefully in 5 years we know more and have a silver bullet or not? But what's your bet? What is kind of
I
your
think
best candidate?
Currently, if we put aside clinical trials, then pegylated interferon would be the best, but it's not an easy drug to have. Patients can have problems with reactivation of autoimmune disorders, which will make them contraindicated. Patients get mood changes, they get flu-like symptoms, so it's not the easiest treatment to tolerate long term. And some of the data shows that patients need to be on it at least 2 years before there's actually a molecular response. So we're talking about many, many years of interferon therapy, and the evidence is more in polycythemia vera (PV), there's some emerging evidence maybe for myelofibrosis, but it's not a treatment that's amazing for all the types of NPN. So I think our hope is clinical trials to have different agents, and there's actually some preliminary research showing. I mentioned about the CALR mutated agents. That's actually really exciting. The first one, the monoclonal antibody, had a presentation in EHA, European Conference this year, showing that patients, and I've seen a few patients who was in the UK as well, had really good improvement in their disease with the monoclonal antibody. So I think we probably have to look to the future to have a better outcome for these patients.
I note, which is great to see a number of colleagues from hematology, and our very own Merit has worked in hematology for quite a while. Any other questions from the audience, or also online? I'm not sure, Darren, whether we can any. Oh yeah. Oh, I see. Okay. Yeah, we can look at it. Any other questions from the audience here? Yeah, Michael.
See, that was a very nice talk. Thank you very much. There's a lot of small biotech companies around these places these days, and a lot of them are sort of focusing on the production of or stimulation of fibrosis and trying to inhibit the stimulation of fibrosis. And have you come across any studies where that is the main activity?
So some of if you went back to the slide on myelofibrosis, obviously that's where it's more important. So the imeltelstat, which is the telomerase inhibitor, there is some evidence that there is some regression of the bone marrow changes. The TGF-beta inhibitors, which I haven't mentioned, also has some effect on there, and also for the bomedemstat as well. But all of these are still very early phase, so I think we need more robust data to answer that question. There is one question online. Should I read out the question for everyone? Okay. So it's Dr. Han Chua who's asking the question. Is saying, given the high thrombosis risk with MPN, do you see any prospect for collaboration with cardiology and vascular specialists? So a very good question. So actually, because we have people here. So when I was in the UK, it was a very big center for MPN, and they actually have cardio-oncologists who will be helping with these patients. And also they have very subspecialized hematologists as well that deal with thrombosis, hemostasis. So yes, I think I see, especially, he hasn't mentioned it, but the patients, especially with the end-stage liver disease from the portal venous thrombosis, are some of the hardest patients to treat. So definitely need collaboration with, our hepatologist colleagues as well.
And for those who are in the cardiology space, cardio-oncology is really an emerging separate kind of entity now at big conferences. You see a full program around cardio-oncology, and they're very, very important. Just another question. I mean, we call these myeloproliferative conditions or diseases or neoplasms, and ultimately they could lead to myelofibrosis. But is there a kind of a sweet spot in between? You would anticipate that if your bone marrow kind of starts to fibrose, there will probably be less proliferation, less cells, while the bone marrow is still capable of producing sufficiently. Is that something you see where you can perhaps remove the therapy to inhibit cell proliferation while the bone marrow is still quite active? Is that kind of something you see commonly, or is that?
No, it's a good question actually. So. So the early stage of myelofibrosis, because it's a myeloproliferative neoplasm, so they actually have really proliferative cell counts, so really high white cells in the 50s, for example. So obviously you give cytoreductive therapy for these patients, but over time, because of the fibrosis encasing the bone marrow, so the hematopoietic cells are finding harder to grow, so they become cytopenic over time, so become anemic, low platelets, low white cells as well. So it is. And during that time, obviously, the main thing we can do is obviously pull back on the cytoreductive therapy, and then hopefully there's another agent that they could have, like for example, JAK inhibitors.
And one last question in terms of consumers. You mentioned on one of the last slides, and congrats to setting up a conference, which is obviously organized around consumers, particularly, and Louise has a lot of experience here in the cardiovascular hypertension space. I can imagine this is probably difficult to discuss with patients. You know, it's very hard to grasp. It's a complicated thing. We come from the hypertension space, which is much easier. Pressure is high, damages your vessel. People understand that. But a myeloproliferative condition where you really also have trouble probably explaining what are the potential risks you may not. How do you kind of approach that communication with the patient and what you give them on their way?
Yeah, so very good question. So speaking to consumers and patients, I think one thing is education. So I think they need to be increased education about what condition they have. And so that's number one. And then the disease risk of progression. And I think that's the thing that patients actually struggle the most. Because imagine being told you're a young person, you have this condition. Not sure, maybe in 5 or 10 years, 15 years, you might have myelofibrosis or acute leukemia. That's, I think very hard for consumers, for patients, because it's like this overhanging cloud that something might happen. And I can't even tell the patient, oh, you are high risk or you're low risk. This might happen, we'll monitor you more closely. So it can make patients very stressed and anxious, which I understand. So I think we need more research in this area.
And very last question, bone marrow transplant. You mentioned that only 10% of patients ultimately qualify it. Probably often it's kind of too late in their disease pathway. But what's the outcome for those who actually receive a bone marrow transplant? What's kind of their survival rates and how do they usually?
Yeah, so if we there's a lot of different factors affecting this. Obviously, how fit the patient. So, for example, a 30-year-old that's a very fit patient versus a 65-year-old with a few comorbidities would obviously affect the treatment outcome. Let's say if we put everything aside, patients otherwise fit and well, the response or success rate is about 30%. So it's not that high, and that's why. And in terms of a bone marrow transplant, the procedure itself, there's actually a very high morbidity and mortality procedure. So we only put through patients who are high risk for this procedure due to the problems that they can have. So if they were lower risk or unfit, etc., then we probably prefer clinical trials for these patients.
Any final chance for a question from the audience? No? If not, please join me in thanking Dr. Xi Ong again.
Thank you.
For a great presentation. Thanks for those online. We still have a bit of lunch left for those who didn't have it. We have another seminar coming up in around 4 weeks, and we'll announce that right in time. So thanks again, and thanks for coming, and please enjoy the lunch. See you next time. Thank you. And thanks for the audience at home.